Today we're talking about cervical disc herniation. It is defined as part of the, it occurs when part of the nucleus pulposus intrudes or into or through the annular fibers of a vertebral disc. A cervical disc herniation has also been known as a ruptured disc, a herniated disc, protruding, extrusion, sequestered, prolapse, bulging disc, or disc with a free fragment. It's sometimes called cervical radiculopathy or a pinched nerve. These words are often used interchangeably. They do mean different things, and they don't all technically mean cervical disc herniation. The main signs and symptoms, arm and neck pain. If the disc herniation is in the central location, they will have bilateral pain and weakness. If it's a unilateral herniation, they'll have lateral pain and weakness. They may have decreased range of motion. Frankly, it hurts. They don't want to move. They may have muscle tonicity and weakness. The onset may be either traumatic or insidious. The quality of pain is usually considered to be a deep ache. If they have a lateral disc herniation, which is the most common, the patient will lean or list away from the side of the herniation because it puts, leaning into it puts more pressure on the nerve root and causes more pain. If it's a medial disc lesion, the patient will lean into the side of the herniation because leaning away puts more pressure. And if they lean forward in a flexed position, that opens up the joint and takes the pressure off the spinal cord. So then the disc components, here's our cervical disc. These are the annular fibers. This is the nucleus pulposus. And there is a thin plate that is both on the superior and the inferior surface of a disc that protects the disc from the bones and the bones from the disc. The purpose of a disc is to allow flexion or allow the vertebra to move and flex to protect each other, to increase range of motion, and to offer cushioning. The disc is surrounded by and contained by the annular fibers that protect its outer rim, and there's there's the ALL ligament and the PLL ligament. Associated hardware that may also be affected directly: ligaments, spinal cord, nerve roots, and facet surfaces. The job of the disc is to cushion one vertebral body from another and give flexibility to the spine. Now, there are 4 stages of a disc degeneration. First, we have degeneration, and that may just be the nucleus pulposus is moving out a little bit into the annular fibers. Then we have prolapse, we have extrusion, and finally it gets so bad that we have sequestration. Now, this little blue blob is sequestered. It is possible that it can and will reabsorb. That is to be hoped for because that decreases the patient's pain and discomfort. If the nucleus pulposus tears into or through the annular fibers, we end up with nerve root irritation and an inflammatory response. The size and severity of the disc herniation does not correlate with the patient's degree of pain, disability, or suffering. Small herniations hurt and disable just as frequently as the large ones. Contained herniation often leaves the patient with a larger and more serious permanent disability when compared to a disc extrusion or sequestration. These disc herniations can occur by direct trauma, shearing, wreck, a fall, car wreck, fight, diving into a pool wrong. They can also occur insidiously by overuse. The guy who keeps working, who's sleeping, who has bad posture, even though it hurts, he overlifts, he causes lots and lots of microtrauma, or it can be caused by degeneration. Disc herniations occur most in men between the ages of about 20 to 45. They tend to lift more than women, and they tend to ignore pain and keep lifting and working through that. But all of these things have your patient saying, ouch. What makes it better? Distraction, walking, exercise, gentle exercise, rest. Okay, so if we were going to do some special imaging, we might take an x-ray in the case of a trauma. That would show us if there's IVF encroachment, encroachment in the disc space, and might explain postural changes. But a definitive special image would be an MRI because it shows soft tissue. The primary orthopedic test is a Jackson's compression test. We have Mr. Jones here has come into our office with pain. We will have him sit in an upright posture, and ideally he's lower than this to protect my body, but I would simply press straight down, ask him if that causes any pain or discomfort.
No.
Okay, and then we laterally flex, and I push straight down again. Does that cause any pain or discomfort?
Negative.
And I laterally flex him in the other direction, and I push straight down. Does that cause any pain or discomfort?
Negative.
If it did cause pain that went straight down his spine, I need to consider the possibility that he has a meningeal irritation or meningitis. But if it had caused pain, it would radiate either into his face or down one of the dermatomes into his arm, might cause zinging, that sort of thing. Additional tests that I could perform would be a Nafziger's test, which would additionally give me the pain either within the dura mater or if it's aggravating his cord symptoms, or local or radiating symptoms down one of his extremities. The Valsalva's maneuver and the Desjardins sign or triad would also, he would tell me whether or not he had some of these issues, and if there was pain that radiated down his extremities. There's a space-occupying lesion in the canal. If it's just in the cord, then it's intradural it's an intradural space-occupying lesion. Okay, we would make adjustments as appropriate. Then we would do ice for 48 hours for the acute first 48 hours, followed by heat. We would do rehab for strengthening his posture and improving it, helping him choose nutrients and hydration, giving him exercises to promote activities of daily living, and helping him eliminate the aggravating factors of his daily living things. We would refer him out if the hard lesion is compressing his cord, or if there's no improvement within 2 weeks. And I think I've covered it all.